Hello everyone, and welcome. Welcome to this audio podcast today. This audio podcast today is part of the Equipoise. This audio podcast is part of a Labstorm Motley. This audio podcast is part of a Storm and Scuttle and Turbulence. This audio podcast as part of the Squakish series or episode, and this audio podcast as part of a Storm Robotics production. Through this audio podcast today, a look at sort of the generics of a symptomology known as proteinuria. So the presence of variable persistent excuse me, a variable and persistent amounts of proteins in the urine are signs can be signs of renal insufficiency or renal sort of parenchymal sort of challenges. Proteinuria and EGFR estimated glomerular filtration rate are a base of CKD elevation. Proteinuria identifies recipients whom is where recipients can be at sort of a risk of progressive renal damage or kidney damage, and increased morbidity. The presence of protein in urine, sort of significant protein in the urine, is a strong indicator, or can be an indicator whether that a recipient is likely to experience progressive renal insufficiency or decline. The association of proteinuria and EGFR improves the capacity the capacity of prediction of CKD or symptomologies as part of CKD. Proteinuria is a marker of renal outcome independent of other risk factors. Proteinuria, now looking at sort of proteinuria and sort of pathophysiology or physiology, the glomerulus produces primary urine by filtering blood, and retains larger proteins such as, for example, serum albumin. Proteins of that or with a molecular weight sort of below 60 kilodaltons, below 60 kilodaltons pass freely through the through the GBM or glomerular basement membrane, and are actively reabsorbed within the tubular through the tubular systems of the renal tubules. The renal tubule reabsorbs proteins and some albumin that passes freely through the glomerulus. 40 to 80 milligrams of proteins is excreted per day. Around 30 to 40% of them are albumin or can be albumin. Universal value for proteinuria does not exist per se. Other factors such as the kind of specimen, avoided urine specimen, and the age of recipient tend to be sort of a synonymous or a synchronous sort of factors in around the symptomology. I look at albuminuria now. A urinary albumin excretion rate of less than 30 milligrams per day is considered as normal. Albuminuria is defined as the elimination of a urinary albumin excretion above 30 milligrams per 24 hours. Urinary albumin excretion is a continuous variable, and a lower value, and the lower values the lower the value the better. In case of levels higher than 300 milligrams 300 milligrams per gram, or 300 milligrams per 300 milligrams per or three, sorry, in case of levels higher than 300 milligrams or above 300 milligrams, the terminology used in in amongst primary and around primary care, for example, is proteinuria. Albuminuria is a sensitive marker for the detection of incipient nephropathy. Now looking at a sort of in around protein classification, so there are five forms of proteinuria in at least where for example for example where for example the where the renal parenchyma, the parenchyma or renal pathology is affected, and where the renal pathology or parenchyma is affected, that is then a form of protein, a form of proteinuria that is interlinked with the pathology. So in around pre-renal, so this is caused by an overproduction an overproduction in around proteinuria, and is observed in hemoglobinuria, rhabdomyolysis, and myelomonocytic leukemia and myeloma, and then there is glomerular. In around glomerular, there is caused by modifications of electronic basement membrane, sort of sort of sort of is sort of sort of changes and modifications, and then there's disturbance. It can be disturbance of the filtration barrier. It can be glomerulonephritis, infection, systemic erythematosus lupus, and there can be neoplasia, and there can be symptomologies where in around glomerular where there is effect in around ABP abnormalities. In around tubular, there is decreased reabsorption of proteins, usually filtered by the glomerulus. Small proteins appear in the urine, observed in a specific sort of kidney conditions or renal conditions, and systemic diseases, and in cases of toxicity caused by drugs and other toxins. And then post-renal. In post-renal, there's consequences of inflammatory infections and hemorrhage processes. There's epithelial tubular cells and proteins to the tubular fluid, and affects the lower urinary tract. In around orthostatic, then it's caused by spine position, and it's caused by hemodynamic glomerular alterations. So, in as part of the diagnostics, initially there's a screening method. The screening method can include quantitative laboratory analysis, and additionally 24-hour urine collections. Although that being said, 24-hour urine collections are not used in sort of routine as part of routine healthcare practices or clinical practices sort of nowadays, but can in cases where patients are or have been hospitalized and are monitored. So, in as part of the screening method, additionally, there is urinary dipstick analysis, screening for proteins, and then there's dipstick analysis for the screening of albumin specifically. In as part of the quantitative laboratory analysis, quantitative methods can help to look for specific forms of proteins or proteinuria in as part of proteinuria, and additionally can be used to determine in around albumin or albuminuria. In around 24-hour urinary collections, they tend to be more inconvenient now, but historically have been helpful and have been helpful, and there is a literature to sort of that can be referred to it can be literature to help highlight in regard to the useful or practical basis of how 24-hour urine collection can be urinary specimens can be and had been useful, helpful in recipients with tubular proteinuria, or follow up on recipients with glomerular diseases or glomerular conditions. In as part of the as part of sort of albumin, looking at albumin creatinine ratio and protein creatinine ratio. KDOQI guidelines had recommended that urinary ACR for diagnosis and follow up in adults is and can be helpful when the ACR, when the albumin creatinine ratio is high, that is more than 500 milligrams. It increase the removal of other proteins rather than albumin urine or tubular proteinuria. So PCR on ACR can be helpful in determining the albumin loss through renal parenchyma or through pathophysiology. And there have been guidelines referred to as previously to recommend the implementation of albumin creatinine ratio or protein creatinine ratio in children or young people. The kidney disease that are often associated with abnormal urinary tract or tubular defects are tend to be characterized by the elimination of small proteins. And then ACR is albumin creatinine ratio is recommended or has been recommended in diagnosis of particular renal conditions and line to glomerular pathophysiology, and protein creatinine ratio or albumin creatinine ratio is used, or it can be used in tubular interstitial diseases. Now looking at proteinuria and CKD progression. The presence of proteinuria is an indicator that the recipient has a high probability of renal disease or kidney disease progression, even with normal GFR. Disease progression and risk of renal damage or renal insufficiency correlates with a degree of proteinuria. Proteinuria is a modifiable factor, but the more it is reduced, the better protection for the recipient from disease progression and end stage renal disease or ESKD. The presence of proteinuria helps identify in around the evaluation of PCR or and/or ACR. The presence of proteinuria helps identify population at risk of CKD. In CKD recipients and suspect or high risk for CKD, albumin and protein excretion in urine may and can help with disease prediction. ACR may be obtained to detect presence of normal glomerular proteinuria. A value of albumin or creatinine more than 2.5 grams per millimole in males and more than 3.5 milligrams per millimole in females, or protein or creatinine more than 22.6 milligrams per millimole per liter are indicative of proteinuria. First morning urine is adequate for detection because of less biological variability and also a good correlation with a 24-hour ACR or PCR excretion. As part of the mechanistics for proteinuria. Proteinuria can accelerate kidney disease progression, and this process occurs through multiple pathways, including induction of tubular chemokine expression and complement activation that lead to inflammatory cell infiltration. Glomerulosclerosis is the progressive lesion beginning at the glomerular capillary wall and the site of abnormal filtration of plasma proteins. Albumin protein urea results from defects in the glomerular filtration barrier, and overload of protein urea appears as a consequence of increased glomerular permeability, enabling glomerular passage of proteins. And as part of the sort of treatments or pharmacotherapeutics, the use of angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, aldosterone antagonists, and renin inhibitors in recipients with proteinuria and CKD has shown advantage and effects on the advantage and sort of positive effects in precluding the progression of CKD. The reduction in proteinuria with pharmacotherapeutics that in pharmacotherapeutics in pharmacotherapeutics that are aligned to mimicking sort of the pathways in around the renin in around sort of the challenges of the renin angiotensin aldosterone system is associated with a long-term renal protection. Due to risk factors, some recipients present response to these therapeutic. Due to risk factors, some recipients may not respond to these pharmacotherapeutic agents, and diuretic therapies is and can be effective in improving some aspects of the antiproteinuric action on the inhibition of the renin angiotensin aldosterone system and the reduction of proteinuria. Although diuretic pharmacotherapeutics is not sort of a form of sort of first line or first line form of pharmacotherapeutics in and around the symptomology in as part of sort of current or modern sort of more recent practices, clinical practices, or in as part of guidelines. So that draws this audio podcast to a close. This audio podcast as part of a Dequapoise. This audio podcast as part of a lab storm motley. This audio podcast as part of a storm and skull line turbulence. This audio podcast as part of the Squakish, and this audio podcast as part of a Storm Lobostics production.